Hello, my name is Dr. Jeffrey King. I'm a board-certified orthopedic hand surgeon. I'd like to talk to you today for a few minutes about a very important topic, pain management after your hand or upper extremity surgery. This is an area that patients have many concerns and questions, which I think are completely appropriate. The questions that we hear most often are, one, how am I going to work with my doctor to help manage my pain after the surgery? I'm very worried about that. And the second is, how am I going to make sure that I don't end up addicted to narcotics after surgery, which people are also worried about, I think, with good reason. So I think the key to this is the understanding that it's a partnership. It's how are we going to work together to manage your pain after the surgery. Obviously, pain is a very complex topic. There are a number of different kinds of surgeries that probably hurt more or less. There are also people's differing perceptions of pain, and two people that might have the same procedure, one person might have a much higher pain threshold or sensitivity to discomfort after the surgery than someone else. So obviously it's going to be a very personalized thing, and it's a partnership between the surgeon and the patient. What do we know? Well, one thing that we do know is that it's probably not realistic to expect that after your surgery you will have zero pain. I think that's an unrealistic expectation. Now, we want to control your pain and we don't want you to be miserable, but I think to expect after almost any surgery to have some discomfort and soreness, difficulty sleeping the night after the surgery, kind of being pretty uncomfortable the next day, I think that's a realistic expectation, and we're going to work with you to try and minimize that the most we can. Certain procedures, particularly hand procedures, which are soft, what we call soft tissue procedures, which would be things like trigger fingers, carpal tunnels, ganglion cysts, different operations that involve making a skin incision and then doing some work, but not cutting, drilling, or manipulating the bone, generally are less painful. And these procedures like carpal tunnels and trigger fingers that take only a few minutes, at the time of the surgery, generally the doctor is going to put some numbing medicine in and around the incision. That medication, depending on what's used and how it's used and what else they add, can last anywhere from an hour or two or three to sometimes up to 18 to 24 hours. And that can be very helpful in the early postoperative period. Most of these kind of procedures at this point, a lot of our patients are taking Tylenol, Advil, Aleve, over-the-counter medications, assuming they're okay with your stomach or your liver or your kidneys, and that's something to check with your doctor. But many of these short soft tissue procedures, people's narcotic needs are very, very low. You may be prescribed a few pills for a day or two, but generally we wouldn't think that you would need much more than that. One of the major adjuncts or things that you can do to help with pain after surgery is keeping it elevated above heart level and keeping ice on it. So those two things, along with over-the-counter medications, can be very helpful at getting people through things like trigger fingers and carpal tunnels and short soft tissue procedures. Now, as the complexity increases for things like distal radius fractures or tendon ruptures or arthritis of the thumb operations, bigger operations that involve more bone work, then generally people are more uncomfortable after that, and we take a little bit different approach. First of all, at the time of surgery, the anesthesia people may be able to talk to you about doing a block, which is a way to put medicine up here in your neck or your shoulder, and that can make your arm numb, which helps at the time of the surgery, and then for a period of time after the surgery. Again, depending on how that's done, that can last anywhere from 12 to 18 hours up to 2 or 3 days if they put a pump in. But that's a good thing to talk to anesthesia about. Again, if we can get people over the first 24 hours, that's usually the roughest stretch. Now, in these bigger operations associated with more trauma or bony injuries and plates and screws and things like that, generally people are more uncomfortable. And what we've tried to do is we've tried to take what we call a multimodal approach to pain, which means pain comes from a bunch of different areas. And so in the past, where we might have just prescribed a Percocet or an oxycodone or something like that and kind of hoped that that would take care of it, now I think we're getting a little bit more sophisticated to try and attack the individual different pathways where the pain is coming from. So all surgeons have a different approach to this, but the idea of multimodal medications to help with pain goes something like this. First of all, if you don't have a liver problem, we are now recommending people take scheduled Tylenol, which is called acetaminophen, and take that kind of round the clock for anywhere from a week or two. Secondly, it's a medication called gabapentin or Neurontin, which is a nerve kind of blocker stabilizer. And so the Tylenol acts on one pathway, the Neurontin acts on a second pathway. You can take things like Advil or Motrin or Aleve, which are called non-steroidals. The common one is ibuprofen. You can take that in addition to the Tylenol and gabapentin. So the Tylenol and the ibuprofen are over the counter. The gabapentin you require a prescription for. And then with all of those things working to minimize your pain, we typically will give you a small quantity of a narcotic, which is what you're used to, Vicodin, which doesn't really exist anymore, Norco or oxycodone, which the concerns about addiction are true. It doesn't mean there's no place for it. It doesn't mean it can't be used safely and effectively. But using it as a part of a larger group of multimodal medicines to help manage your pain, that seems to be very effective at keeping the need for the narcotics down. So after one of those bigger kind of surgeries, it's very common that you might need to take those kind of the medications for a week or two, generally not much more than that. And then using the narcotic medication for the first day or two or three, but kind of weaning off of that pretty quickly. So again, it's a complicated topic. It's a very, very important topic. And I think it's something that you for sure want to have a conversation with your surgeon about before the surgery rather than after the surgery, because it's much easier to have that conversation before you do the operation. But hopefully this discussion will help you understand a little bit of the rationale and the treatment options that we have to try and help keep you as comfortable as we can after the surgery. Thank you very much.